Okay. Here she comes. Rachel, you don't have to turn your camera on if you don't feel like it. Okay. All righty. So we have a nurse caring for a 31102. So what's her gravida parida? 31102. Is she multi-gravida? Multi-para? Prima gravida? What is she? If you're trying to speak, you're muted.
She's going to be multi-gravida.
Multi-gravida. What's her parity status? How many babies has she delivered after 20 weeks? 2, right? She delivered 2 of them after 20 weeks. And she's got the 2 living children. So she's multi-parity, right? Or we call them multiparous. Okay. She has a history of preterm, substance use disorder, and gestational diabetes. She's in labor now with her partners helping her and a doula, and a midwife. It comes in to assist as well, and she calls out shoulder dystocia. And the nurse immediately calls for the interprofessional care team and then begins to provide assistance. Does anybody know what shoulder dystocia is? What about the word dystocia? Do you know what we mean by dystocia?
And it's getting stuck.
Okay.
Getting stuck. Very good. Very, pretty accurate. So we got something going on. The baby's shoulder is stuck. Okay. So I don't have a picture for you. I can show you later. So let's fill in the answers here. Okay. So the patient has a history of what? And this is a risk factor for having a baby get stuck. Okay. For shoulder dystocia. So out of option 1, which one would be a risk factor? For shoulder dystocia?
Gestational diabetes.
Yep. And why would this client, why would that be a problem?
Because the baby could be macrosomia or too large.
Yeah, a large baby. So our gestational diabetics or our type 1 or type 2 diabetics, they have larger babies. And not only are they just got more fat on them, but their shoulders are even broader. They have a bigger trunk. So this is very typical, shoulder dystocia of a diabetic. Okay, good. So that's number 1. What about the anterior shoulder cannot pass under what? In other words, as the baby is descending, navigating through that canal, that anterior shoulder can't pass through what? Pass under what?
The pubic arch?
Mm-hmm. Yeah, it's the pubic arch or the pubic bone. Yeah, I'll put arch. Pubic bone. Oops. I did. Either one. Yep. Good. Signs of possible shoulder dystocia include what sign in which the fetal head retracts against the perineum immediately after birth?
Turtle.
Turtle sign. Yeah. It'll pop out, then it'll want to pop back in because that shoulder is stuck, if you can imagine that. So it's the turtle sign. Okay. The next one, the nurse follows directions given by the provider. These include what? Which maneuver are we going to do here? You're muted, Crystal?
McRoberts.
Yeah, the McRoberts maneuver. Okay. Which is the knees flexing. And then what kind of pressure do we apply?
Pubic pressure.
Suprapubic, right above the pubic bone. Okay. Because that will help depress that anterior shoulder that's caught up there. So if we just put some slight pressure on that suprapubic area, we will, if you press on the pubic bone, you're not doing anything. If you're able to press on that pubic bone and do something, you're going to break it. Okay. You have to do right above it, which is kind of on top of it and kind of at an angle. Okay. Pushing down. And that helps that shoulder to move out underneath that pubic arch. Okay. That gives you one scenario that we're talking about this week, difficulties in labor. Okay. So let me find something else for us to do. It's hard to believe it's already week 6. I gave you this PowerPoint. This one is a great PowerPoint for you to go through and fill it out as a preparation for exam 2. So the first one is prolapse cord. Okay, what would you see? What would you do? And we can go over this together today. And then labor dystocia. So shoulder dystocia is a labor dystocia. Okay, it's a form of it. It's not exactly a form of it, but it's one dystocia that can really hinder labor. Okay. And then we talked a little bit about this last week, the placenta previa and the abruption. So you can play with that and try to remember what's what. Preeclampsia. Okay, you need to know it backwards and forwards for your exam. And then the management of preeclampsia, and we can go over that again today. And then differential diagnosis. So because molar pregnancy, hyperemesis gravidarum, this is all content for your exam. All right. So I gave that to you to go through and to study from. Okay. So this is the PowerPoint you said you were having trouble with. Okay, let's go over the first question. A client is to have an amniotomy to induce labor. What is your priority intervention after the procedure is completed?
Fetal heart rate.
And why is that, do you think?
Because you've just broken the lady's water, so you need to see what's happening with the baby.
Okay, so when all the water is draining out, all the amniotic fluid is coming out, it actually causes that fetus to be less buoyant. Okay, we want to make sure that there's still adequate fluid so the baby can move around and not have any distress, and to help prevent the prolapse of the cord. So we want to assess the fetal heart rate. Okay. So we look at the monitor, and if the cord was prolapsing, in other words, if the cord was falling down into the uterus and getting pressed against the cervix, what kind of a fetal heart monitor would you expect to see? What fetal heart pattern would you see? Do you remember your veal chop? What kind of heart pattern would you see?
Variable or prolonged dissolves.
Yeah, variable for sure, okay? Because that every time that cord's pressed, the heart's going to drop. So we usually see a very sharp V. And whether there's a contraction going on or not, okay? So it's variable. Good. So understanding something normal, especially the birth process, helps you to recognize what's abnormal. That's the way we teach counterfeit, recognition of counterfeit dollar bills or some kind of money, is to really know what the normal is. And then when you're looking at a bill, you'll recognize counterfeit. Okay, so the same thing as nurses, we have to know what's normal. And so we're going to help prevent deviations from normal labor and delivery and birth, and at an early stage. Okay, so knowing that you have a client that's a diabetic or a client with a big baby, you know she's at risk. So our expected management is that she might have trouble during labor with some dystocia, or her fetus might have some shoulder dystocia. Okay, so we know when to implement measures. We don't wait until the provider gives us an order to do suprapubic pressure and Gaskin and McRoberts maneuver. We don't wait for an order. We know this is what we need to do. Okay, so and in labor and delivery, yeah, you work as a team. Teamwork is so important. So no matter what field you're in, you've got your coworkers there, and build a good relationship with them. Don't let personal things get in the way, and you don't utilize each other for difficult clients. Okay, preterm labor and birth. What is preterm? Well, it's after 20 weeks, right? Because anything that's delivered before is considered an abortion. Okay, so those babies born after 20 weeks, but before that 37th week, are considered preterm. They're premature. Okay, they're probably, if they're born before the 35th week, their lungs are not going to be mature. Okay, so normally what we see in a woman with preterm labor is she will have regular contractions and cervical changes. Okay, but her contractions are going to feel a little bit different. She's going to have more pelvic pressure and back pain. That's usually what we see with preterm contractions. So preterm birth, which is age, right, and prematurity are two different things. Okay, prematurity can exist. It describes the length of the gestation, whereas preterm birth is well, the length too. But what we have to do is we have to look not only at the immaturity or the prematurity, but the weight of the baby. Okay, so a low birth weight baby from an adolescent could be full term and still be at risk because of the weight. So prematurity is much more severe than low birth weight. Okay, so a low birth weight are those babies that weigh 2,500 grams or less. Okay, intrauterine growth restriction. Usually coincides with low birth weight. Restricted growth, something going on with the placenta or with mother's health. So let's list some of those things, some things that prevent a fetus from growing adequately. High blood pressure, maternal hypertension, either chronically or gestational. Okay, poor nutrition, nicotine, something that affects a good blood flow to the placenta, high blood pressure. Okay, adolescents, elderly people, drug use. Those are my dogs, if you can hear. So a spontaneous preterm birth, it just occurs on its own, okay? It occurs on its own. So a baby that is a mother that goes into labor between 20 and 36 weeks and 6 days, that's a spontaneous premature birth. An indicated preterm birth is a situation where the baby's going to do better even if we have to deliver it prematurely, because either it could be the baby or it could be the mother's health. If the mother gets really sick, or she has a pulmonary embolus, and she's only 36 weeks along, we're going to have to deliver the baby. Okay, so indicated means something is occurring that's at mother or fetus is at risk. So it's indicated that we go ahead and deliver the baby. So there's a box on page 17.2 if you want to look at that. Preterm labor, what are some causes of preterm labor and birth? The most common is infections. Usually genital tract or genital urinary tract. So urinary tract infection or sexually transmitted infections. And then your African American clients are more at risk for having a preterm labor. If the mother's uterus has an anomaly, if she only has she has what's called a didelphys. In other words, she has 2 uterine bodies that are connected, but only one is really functional. So the fetus is only in half of the uterus. Okay, so some kind of uterine anomaly. Artificial reproductive technology assistance or assistant reproductive technology. In other words, in vitro fertilization, embryo transplant, all those fertility procedures are at risk for early labor. A woman with twins or triplets could possibly deliver early. Nicotine, substance use. Low BMI before pregnancy, like a pre-pregnancy BMI of 17.5 or greater than 30. Periodontal disease, that's in the gums. Tooth abscess can cause early labor. When you have a serious infection like that, it can spread rapidly throughout the body. When there's an infection like that, inflammatory markers, cytokines are being circulated, and sometimes prostaglandins are released. So you have early labor. Late to prenatal care, poor prenatal care, or socioeconomic and education status can contribute or are associated. Let me put it that way. And last week, we talked about incompetent cervixes, incompetent or insufficient cervix, a cervix that's too short. If we don't band it, if we don't put a cerclage around it, she's going to deliver early. Okay. This is a great picture of that. Most of the time we see the cervix that's short when we do ultrasounds. We do an ultrasound, early enough in the pregnancy, we can measure the cervix. Once she gets 30, 32 weeks, we can't measure it as easily anymore. We can't see it as easily. And if a woman has a incompetent cervix during one pregnancy, doesn't mean that she'll have it with another one. Okay, and here's a picture of a cerclage. A circle and a stitch, and it closes it up. And so this would be a vaginal procedure. And then we can also suppress labor with medications. If our client comes in at 34 weeks, 33 weeks, and she's in labor, we can try to give her some tocolytic. In other words, we're stopping contractions. They're called tocolytics. The most common one we might use is terbutaline. Magnesium sulfate is not necessarily a tocolytic, but it will help the uterus relax. And we're giving it for really another reason. Does anybody know why we would give magnesium sulfate for a mother in preterm labor? Thomas Davis is nodding his head.
Is it so
For preterm, you said labor, it makes it starts contractions, don't it? Like,
No, we don't want to start contractions. She's having contractions. No, magnesium
but-
sulfate.
it helps to prevent or treat seizure activity?
Okay. Well, she's not prone to seizures. She's just in labor too early.
Is it to prevent the baby from having cerebral palsy?
So remember what it does when we give it for preeclampsia? Remember we talked about it helps relax those cerebral arteries. It improves cerebral perfusion. So it provides the best glucose and oxygenation that the brain needs. So if we give it to mother, the baby's getting it too. So with preterm labor, if it's inevitable, we definitely want to put mom on some magnesium sulfate to protect the fetal brain. Okay, so we're also protecting the fetal brain. And yes, it helps prevent cerebral palsy. It's considered an off-label use, but magnesium does have a little bit of relaxant. Okay, it's going to make mother feel warm. When you infuse it, it gives mom a funny feeling. She's going to feel warm and tingly. And it does tend to relax her a little bit. So terbutaline is a beta adrenergic agonist. In other words, it's affecting the heart and the blood vessels. Okay, so it also relaxes the smooth muscles, which the uterus is a smooth muscle. So terbutaline relaxes the uterine muscle. Now remember, if we have a drug we're giving to relax the uterine muscle and it's an agonist on the beta receptors, it's also going to what? Increase the heart rate and the blood pressure. So contraindications would be a client with high blood pressure. Sometimes if we're able to stop the labor, we can put her on other medications to keep her uterus relaxed and postpone delivery. So some of those are indomethacin, which is an NSAID, anti-inflammatory, prostaglandin inhibitor type drug. You can only use it for a few days. Okay. We can also use nifedipine, which is on here. Nifedipine is a calcium channel blocker. Okay, for smooth muscles in the heart. Okay, we can use nifedipine. And sometimes providers will consider nifedipine the drug of choice for our clients with gestational or chronic high blood pressure. Put them on nifedipine. Not only will it help the uterus to relax, it'll help improve blood flow and it'll help keep her blood pressure down. Nifedipine, Procardia, it's not on the list. We're not going to suppress any preterm labor if we suspect an infection, like an infection in the amniotic fluid, an infection in the uterus, because we need to rescue the baby, okay, and treat mom. So if she is developing chorioamnionitis, which is the infection in the membranes, the chorion and the amnion, the sac that's holding the amniotic fluid, and the fluid itself has an infection, what would be a sign of that being of having chorioamnionitis? What would you expect clinical signs to be for chorioamnionitis?
Mom and baby both are going to be tachycardic.
Why?
Well, I'm guessing if she starts running a fever from the infection, that's going to do something to both of them's heart
Yep.
rate.
Yeah, so a fever is a sign of, so if her temperature goes up to 100, 100.1, 100.2, then we're concerned that she's got an evolving chorioamnionitis. So we're not going to stop labor. It's contraindicated. If the umbilical cord is prolapsing, if it's dropping down and she's having variable decelerations, we're not going to stop labor. We've got to deliver the baby. That's the only resolve. And then, of course, if the placenta is pulling away, abruptio placentae, if it's rupturing away from the uterine wall and there's massive bleeding going on, we can't stop labor. We have to get that baby out. So with our preterm labor babies, if we're having trouble stopping labor, we have an expectant management or very active approach to managing preterm labor. And it's about the safety of the fetus, okay? So not only are we going to be giving magnesium sulfate, we're also going to give mom an injection of betamethasone. Okay, now why are we giving her betamethasone? But what will the steroid do for the fetus?
Help develop the baby's lungs.
Yeah. So we are promoting surfactant production by the fetal lungs. Okay. And even if we have a client that's in the office and doesn't have any signs of preterm labor, and she's about 33 weeks along, if she's had a preterm delivery before, we might go ahead and give her a steroid. That's kind of provider dependent. Okay. So if she's between 24 and 34 weeks with signs of preterm labor, that's when we can give the betamethasone. It doesn't do any good to give it after the 34th week. And if we did, we might cause more problems. Premature closure of the ductus arteriosus. Okay. So and it was one of your calculations, I think, for your first set of calculations, your assignment. We give 12.5 milligrams one day, and then she returns the next day, 24 hours later, and we give her the second 12.5 milligrams. Intramuscular injection. Okay, so once again, if she's dilated at 4 centimeters already and she's having some contractions, it's kind of inevitable. There's not very many preterm deliveries that we can divert, okay, or not divert, but prevent. Okay, so we're gonna go ahead and get the magnesium started. We're gonna notify, and hopefully there's a nearby tertiary care center that has the equipment that we might need, resuscitory equipment, and the trained personnels, neonatologists as well. So if it's early, preterm, a lot of times that baby is not in a head down position yet. So malpresentation of the fetus might not be longitude, might not be cephalic. It might be breech position. So we need to be prepared for that as well. So we have to have the neonatal resuscitation team. The number one reason for a newborn to be admitted to NICU is preterm birth. Okay, preterm status. There's another term, premature rupture of the membranes. In other words, she calls the office or she comes to the emergency room and said, I think my water broke. But she's not having contractions. So that's prematurely rupturing. Okay, that's premature because there's no contractions. Okay, so if her sac breaks and she's not in labor within an hour, then it's called a premature rupture of a membrane, no matter how far along she is. Do you remember how we test if it's amniotic fluid versus urine?
Is it the strip test?
Right, yeah, litmus, nitrazine, strip test. And we want to check the acidity, the pH level. Preterm premature. Okay, so this is rupturing of the membranes before that 37th week. Okay, so this is preterm premature, PPROM. If the membranes rupture at 38 weeks, it's just premature rupture. But if it's before the 37th week, you have to tack on that preterm. Does that make sense? So infection is a major risk factor for premature rupture of the membranes. Okay, if the membranes leak, that means the transmission of bacteria up into the amniotic fluid and around the baby is bacteria are now, the channel is open so that can be transmitted, vertical transmission. And the membranes, when they rupture like that, they're weaker because there's some inflammation going on. So, and then the stress from uterine contraction can cause the premature rupture and premature birth. And this slide, I've got the word chorioamnionitis separated out into the different syllables because it helps you remember the word plus what it is. So chorio is the outer membrane of the amniotic sac, and the amnion is the inner membrane. So there's two membranes together. And so they contain the baby with the amniotic fluid. So when the chorion and the amnion become infected, it's called chorioamnionitis. Okay, so bacterial infection, maternal fever, fetal and maternal tachycardia, uterine tenderness, and the amniotic fluid is going to smell foul, and it might even be discolored and purulent. Okay, so that's your chorioamnionitis. So what do you think is the number one fetal outcome with chorioamnionitis? If we left it untreated, what do you think it would cause the fetus? What effect? What's the baby doing during the antepartum life? moving around. What else? Swallowing amniotic fluid, right? So number one is pneumonia. Okay. It's the number one outcome of chorioamnionitis for the fetus. And the mother, it's endometritis. In other words, infection of the uterine tissues. Endometritis. Post-term pregnancy at 42 weeks and beyond. Greater than 43 weeks. It's really equal to 42 weeks. I think your text says 42 weeks. A client that carries a pregnancy to 42 weeks is at risk for a large baby, less amniotic fluid. So the baby's at risk for injury and not able to move. Dysfunctional labor. Injury to mother's perineum because of the largeness of the baby. Macrosomia. Hemorrhage and infection. Oligo, which is small amount of amniotic fluid. Fatigue and psychological factors associated with labor and delivery. It's more likely that we have to use forceps to deliver the baby or vacuum assistance or even a C-section. So with a post-term pregnancy, baby is large, so baby could actually sustain some injury. The placenta is getting old. Remember, we discussed the placenta as a temporary organ. It's only meant to take care of the fetus, provide the fetus oxygen and the nutrients. By the time we get to 42 weeks, it's starting to calcify and get old. And then, of course, if it's not working as efficiently, we don't have much amniotic fluid. All our high-risk women at least during the late second and third trimester, we are doing fetal surveillance. Okay, we're monitoring the babies with ultrasounds, and we can do a growth every 3 weeks. We can do BPPs as often as we want to. So, remember the BPPs. It's just an indicator of fetal well-being. It's a way of measuring, is the fetus thriving? Baby can move okay, the reflexes are working, babies practice breathing, and amniotic fluid amount. Okay, so it's a fetal well-being. 8. So there's 4 parameters, and they're 2 points each. So if we do it, but we're not seeing baby practice breathe, we're going to give the score of 6 out of 8 BPP. Okay, so if it's any lower than 6, then we're concerned about fetal well-being, and we might need to deliver the baby. And then non-stress test. Remember, we do those to see how baby responds to its own movement. Is the baby's heart rate going up when the baby moves? That's a non-stress test. Another indicator of fetal well-being as we survey our fetus. Dysfunctional labor or dystocia. Anything that hinders the progress of labor. Remember our 5 Ps, the passenger, the lie of the passenger, the size of the passenger, the presentation and the position of the passenger can all affect labor progress. Okay. The powers. Our mother's uterine contractions strong enough? Are they occur often enough? Her pushing, is her pushing adequate? And then, of course, the passageway would be mother's anatomy. That affects labor. If she has a very narrow pelvis, there might be some disproportion there that we can't deliver vaginally. And then mother's position. Is she not trying to do some positions that might enhance labor, like squatting or standing, to allow gravity to help? And then what's her emotional status? Is she very anxious, scared, mad? That can hinder labor too, and cause dysfunctional labor. So those clients who are at risk for dystocia: short women or short stature women, obesity, advanced maternal age, uterine abnormalities, malpresentation. This is kind of a repeat. Okay. If her oxytocin levels are too high and she's having too many uterine contractions, the contractions aren't effective because they're not they're occurring too quickly, and the blood flow of the uterus is not returned. Okay. You don't need to know the specifics about the different kinds of dystocia, hypertonic, hypotonic, protracted, all that. You don't need to know all of that. Protracted labor, in other words, labor that goes on too long. It's occurring beyond those 20 hours. Now, that's what we call protracted. It's just taken forever to get anywhere. There's risk associated with that, like infection. Number one, the baby could develop pneumonia, meningitis, demise. Do you remember we talked about group beta strep organism? Group beta strep organism. It's the streptococcus strain that some people carry in their urine, in their bowel, or in the vagina. And normally it doesn't cause a problem, but during labor, that group beta strep can actually invade the amniotic fluid. And that's usually what the cause, that and E. coli are the causative bacteria for chorioamnionitis. Okay, so we have to treat it with penicillin. So remember precipitous labor? When you mark, get set, go, we're done. Okay, 3 hours or less. It puts mother at risk for placental abruption, okay, hemorrhaging, postpartum injuries. Obesity, hypertension, diabetes, they all kind of go hand in hand together. They overlap. Obstetric procedures. I have a better slide set than this. I might pull up some pictures in a bit here. So external cephalic version, we don't do this too often. This is a situation when we have a client that the fetus is not in a head down position. It's not cephalic and it's off. And so we're going to do try to relax the uterus a little bit and give the mother some pain medication. But we first need to do an ultrasound to verify that what position the baby's in, and then we can begin to try to move the baby. What's this?
That's the vacuum assisted birth.
Okay, so this is probably the safest way to assist in delivery of of a fetus. And there's various reasons for doing this if there's just not good progress. But in order to do this, of course, mother has to be completely dilated. The membranes have to be ruptured. If she has some kind of musculoskeletal disease and she doesn't have the strength, or maybe she had an epidural, she's having trouble pushing, we might assist her with a vacuum assisted. And so there's risk associated. I want to find my other PowerPoint for you. Okay. Sorry about this. Let me look for something. Look for something. Let's see. Previous quarters. January. Weeks. Week 5. No. Why don't we, I think I'll have you have you go on break while I look for that. And something else I wanted you to do. And so let's take a break for a little while. It's 12 after. So right before 4:30 or whatever your time is, 3:30 for those of you in Cookville. Okay, so we'll meet back together then and I'll get it for it. Okay. But let's go back to labor induction. If we have a client that is post-term, or there's something going on with her, if she has a pulmonary embolus, of course, it's going to be an emergent C-section. But if we need to go ahead, it's indicated that we induce her into labor. Then we have to do a good assessment, okay, to see how to do that. We can't just hook up some oxytocin and start contractions. We need to see what condition her cervix is in. Is her cervix beginning to soften and dilate already? And the more it's dilated and the softer it is, and the better positioning, it's going to make labor a lot easier. So we want to kind of get her as far along as possible before we start her contractions. And we do that by ripening. We call it ripening the cervix. Okay, so this is something done, during the 39th week or later. So in assessment of the cervix, we use the Bishop score, which we've talked about like week 2. But this is just another graph of what it is. So Bishop score is telling us if the cervix is dilated, we give a score. If it's effaced, we give it a score. If it's soft or firm, what position. A cervix becomes more anterior. In other words, anterior is the top wall of the vagina, okay? So I'm
Professor,
think of it as what?
I just sent you a message. I need to leave the meeting.
Okay, okay. I hope everything's okay.
Thank you.
Uh-huh. Okay, so usually cervix will become more anterior the closer she gets to labor. And then the station of the baby, the fetal station, where is the baby in relation to the pelvic structures or the pelvic anatomy? Is this baby at the level of the ischial spine? Is it a negative station? And then we add all those up and it gives us the Bishop score. So we like that Bishop score to be 6, 7 before we get started. So we want her somewhat effaced and dilated. So if not, then we're going to use what we call a prostaglandin, most common method. A prostaglandin is a drug that we actually put into the vagina. We put it behind the cervix in the fornix of the vagina. So it's kind of behind the cervix up next to it. And this will help that cervix soften. Okay. We can also do mechanical dilation. It's similar to using a Foley catheter and slowly inflating it over a period of times. It causes that cervix to open up. And we can do an amniotomy like we talked about at the beginning of class. Sometimes just rupturing the membranes will start labor. Okay, so this is what we call induction of labor or ripening the cervix first. So to actually start contractions, we're going to use a uterotonic like oxytocin. It's the natural hormone that the body releases when a woman goes into labor. So we're going to use a medication form. And you worked on some problems trying to solve and calculate how much an hour you run a bag if the order is for 2 milliunits. Remember, your oxytocin must be plugged into a primary line of LR or normal saline. It will cause uterine contractions. It also causes breast milk relaxation or ejection. Okay, so oxytocin is a high alert drug. Very short onset. Doesn't take very long. Once you get it into that vein, start contractions. And it's very duration. So we give it continuous infusion on a pump. So think about the safety factors of it. It's always good to double check the rate with the order with another nurse. Some facilities might require that you have a double check. Adverse effects of oxytocin are going to be too many uterine contractions. So uterine tachysystole, rupture of the uterus, okay, or placental abruption. And if there's reduced blood, if the uterus is contracting too much, then it doesn't have an opportunity to relax, to be reperfused, to allow that placenta to be reperfused. And then, of course, infection. So we use oxytocin to initiate contractions. We use oxytocin to augment or to make, if a mother's having contractions, but they're not very strong, and she's only having maybe 1 or 2 in a 20-minute period, we're going to go ahead and give her some oxytocin to make it a little more progressive. And then we use it for postpartum bleeding. Okay, so it has quite a few uses. So I do have the oxytocin calculation here in the proportional method, how to remember to always calculate using milliunits. Okay, if you use dimensional analysis, you will be converting it right away. Okay, because there's 1,000, or I should say 40 or 20 units is the same thing as 20,000 milliunits. Okay, so I just recommend always converting it to milliunits as your first step. Okay, and then determine how much of the oxytocin is found in 1 ml. So I set it up this way. And Thomas, this is what I was looking for earlier when you and I were talking. I couldn't find it. No wonder I couldn't find it. Okay. And then as you titrate it, if you titrate it by 1 milliunit, and in this calculation, you figured out that you needed to give 0.1 milliunit per minute to give the 2 milliunits. So if you're going to bump it up to another milliunit, you're going to bump it up 0.05 mLs. Okay. Okay. So you can take some time to look through that one. All right. This is just another one, titrating it, which is the answer on your OB Calc. And then higher doses. We had a problem with 500 milliunits. Okay, so it tells you how often to do this. Okay, vacuum assisted delivery. We were already talking about this. Remember, cervix has to be completely dilated and effaced. Membranes have to be ruptured, and there's no risk of any CPD, or cephalopelvic disproportion. In other words, the head of the fetus should fit through the pelvic anatomy. Okay. And of course, vertex presensation, which is this part of the head. Okay, so that we can attach. That's the criteria for using a vacuum assistance. Okay, so this can cause laceration in her perineal tissues, hematomas. For the fetus, it can cause what's called a cephalohematoma, where the fetus has a hematoma on the head in the scalp. Subdural scalp lacerations, and then of course, subsequently will develop hyperbilirubinemia or neonatal jaundice. Forceps is a worst case scenario. If we have to use forceps, because they're an instrument and they're hard, and even though we place them around the baby's ears and the head, right in here, we lock them so that when we're pulling and applying negative pressure, we're not squeezing anymore. So they are locking. Okay, but still there's risk associated with this, and the only thing you have to know about is forceps birth is just a procedure, okay, for dystocia. When we talk about high-risk newborns, we go into more detail of what the consequences are for having to use this. So for mother, laceration, urinary retention, so we can damage her bladder using these forceps. And then there's women who have had a C-section. Their very first pregnancy and delivery was a C-section. So they're actually cutting into the abdomen, clearing away all the muscle and the fascia, and getting to the uterus and cutting into the uterus. And it depends how they did that. Did they do a low transverse or a low vertical, or a classic higher up incision? The classical incision really cuts into a lot of uterine tissue, and we really don't promote having a vaginal delivery after having that kind of a cesarean surgery. Now, some of the low horizontal, transverse, or vertical, we could do vaginal delivery for the next baby. Okay, so vaginal birth after a C-section is called a VBAC. Okay, And the TOL is what we call trial of labor. So if a client has had a cesarean section for her first delivery, and it was not a classical incision, we can let her go into labor on her own spontaneously and let her labor down for a few hours to see if she's progressing nicely. And if there's no complications and it's progressing nicely, we can let her deliver vaginally. But if she's laboring for 4, 6, 8 hours and there's not much progression, we'll go ahead and do another C-section. Okay, so the trial is just to see if she has progression in a safe manner. Okay. If she had her C-section 8 months ago, no, we have to wait at least a year before she can deliver vaginally. It takes a long time for that uterus to heal. So the plan would be to, do an ultrasound to look at the position of the baby if she goes into labor, and then measure the pelvis again. That's what pelvimetry means, to measure the diagonal lines and the vertical lines of the pelvis to see if it would work. Most cesarean sections are elective. Okay, there are occasions when we have to emergently do one, as we've talked about. Okay, and there's certain heart conditions that we don't want our client to labor through. If you have someone with heart disease, it's a balance. Do we let her labor and work hard, even though it would be hard on the heart? But then do we do a C-section, which puts her at risk for clots and heart problems? Okay, so it's a balance of her overall health, and possibly doing a spinal and a C-section might be the best thing. So with a C-section or cesarean surgery, it is invasive, it's surgery. So we need consent. Okay, we need a consent for the surgery. We need a consent to give blood if we have to. We need to type and cross. We need a consent for anesthesia. We need to do some extra labs and apply the sequential devices and a Foley catheter. If we're doing an emergency C-section, of course, it's going to be a general anesthesia. Okay. Any questions so far? Rayford left us, or maybe he had to go to the bathroom. Okay. So this just talks about C-sections again that you can look through. Meconium stained amniotic fluid. If our during labor, if there's a lot of late decelerations, the baby is experiencing some what am I trying to say? Hypoxemia, and then hypoxia. That the level of carbon dioxide retained can cause a release of stool. Okay, so it's called meconium. The first stool that a fetus passes or a newborn passes is called a meconium. So if you have a client in labor and you see amniotic fluid that's green, you know they've already passed stool and they're stressed. So this requires you calling the high-risk team again, resuscitation. Because what will happen is that once that baby is born, they could aspirate the meconium. Okay, this is a shoulder dystocia again. Umbilical cord prolapse we talked about. So in these pictures, you notice that the cord is getting ahead of the fetus. In a breech position, it's more likely to happen, or a baby that's not really engaged. In the picture on the left, you can see that cord actually falling out of the the cervix. So what's our resolve? What do we do for umbilical prolapse? What do we do?
The nurse needs to make sure she stays with the patient and have someone else call for help. And if the umbilical cord is seen protruding through the vagina, she can wear gloves and try to relieve the compression from the cord, reposition the mother on a modified Sims position or knee chest position. Give oxygen, increase fluids, and monitor the fetal heart rate.
Good, good, yes. So if you see this, what would you see on the monitor?
The variable or prolonged decels.
Okay, variables and decelerations, because you can see how the head is pressing against that cervix or that umbilical cord. So that stops blood flow to the fetus. So you're going to see the V-shaped decelerations. So the very first thing we do need to do is to stay with the patient and reposition. So knee chest position. Okay, knee chest position.
I have a question.
Yes.
Okay, because that was like a question we had on our quiz, and I was distinguishing between the two. I'm like, stereo push back in, okay, but you want to put her knee chest position. So what would you do first as the nurse? Would you do the stereo glove, or would you just put her in the knee chest position?
Knee chest position. Okay, knee chest position, because that'll be the greatest help for that fetus to fall back down into the uterus, away from the umbilical cord. Okay, and then you've got your team in there, and we're headed to the OR. And so in this, you also can, if you have the opportunity, to go ahead and get your supplies, sterile gloves, and you're going to press on the presenting part, not on the cord. Okay, you don't want to press on the cord because you're pinching it if you're pressing on it. So we're going to push on the head instead, to push the head out of the way. Okay, so you see in these positions how that baby actually would fall back down in the uterus, at least fall a little bit away from that cord. And then you can put your sterile gloves on and push on that baby's head, okay, to get it away from the cord. And then the idea of sterile towel and a sterile saline is to keep, if the cord is actually coming out of the vagina, to keep it moist. So this is what you would see for uterine rupture in this picture. So if a client has had a classical scar or incision and scarring, and she goes into labor and she's allowed to labor, it could rupture. It's rare, but it could happen. It could happen. So what you would see on the monitor is what you see right here. Decelerations, then all of a sudden losing variability in heart rate goes out because there's massive bleeding. And then obstetric emergencies. What are some of them? Amniotic fluid embolism, of course, pulmonary embolism. We treat them the same, actually. Anaphylactoid syndrome of pregnancy is another word for it. Okay, so your client is going to have the same symptoms. It's sudden shortness of breath, dyspnea, because the pulmonary artery is being blocked and the lung can no longer exchange gas. Okay, because of amniotic fluid. Now, this is usually during labor and delivery specifically, so early postpartum. Okay, coagulopathy, acute hypotension, hypoxia, DIC. Okay, this also, you see this same follow through with abrupted placenta, coagulopathy, cardiovascular collapse because of blood loss, acute hypotension, hypoxia, and DIC with an abrupted placenta. Precipitous labor, this can be caused by precipitous labor as well. So in an emergency situation like this, we do CPR for about 4 minutes on mother to try to resuscitate her and improve hemostability. If we're not successful, then we're going to do an immediate C-section to try to save the baby. Okay. I will get that PowerPoint slide to you. I remove the other one so you'll have it. Okay. I apologize for giving you the wrong one. Okay, so let's do something else. For the last little bit here. Because I want to practice. And I know this might be familiar to you, but let's talk about the prolapse cord again. Okay. So tell me, as a nurse, if you have a client, you're suspecting a prolapse cord, what is it that you're seeing that makes you suspect that? And this is an umbilical cord, of course.
The first thing you might see the variable D cells, and you might see or feel the cord in the vagina.
Yeah, yeah. So you're probably going to see the variable decelerations. And then you might actually observe the cord. Okay. So, and do you remember which clients that we might suspect higher risk for an umbilical prolapse, umbilical cord prolapse? Do you remember what situations we might know our client is at risk?
If the baby is in the breech position,
Okay, breech position. Okay. If the baby's not engaged. Yeah, we don't see this very often. Dr. Roberts still works in OB, and she told me last week she actually had a prolapse occur. So what are we doing with the prolapse cord? What's your first thing that you need to do? Hannah, do you know?
Oh, you put them in a knee chest position and then put on a sterile glove and you're gonna push the presenting part off of the cord.
Okay, okay. And what else can other people be doing? What else we need to do for her?
Give
while
her
we're
oxygen.
getting her ready? Okay, oxygen, yeah. And fluids. And then somebody, you already asked someone else to call the provider and the OR. Okay. Good. Labor dystocia. Labor dystocia could be, we're not even going to do that one. Did we do this one last week with you? Did I do this one last week with you? Okay. So placenta previa. Which one of the pictures below show you placenta previa?
we are not seeing your screen.
Oh,
Can't see the screen.
no wonder you don't know what I'm talking about. Okay. So which one of the pictures? Placenta previa. Number one, Rachel put her hand up. This one. Yep. That's a previa. Previa means first. Okay, so you can see where the placenta is covering the internal os, the opening to the cervix. Okay, where the delivery takes place. So if that placenta is there, is preventing the baby from being delivered without a whole lot of bleeding. Okay, so she might be bleeding early in pregnancy with the previa. And as she progresses in her pregnancy, we have to monitor her and her baby. We have to monitor and ask her and teach her about bleeding. She might feel a lot of pressure in the lower pelvis. And we might have to deliver early, which is a C-section. Okay, so it's not necessarily emergent C-section, but the abruption would be emergent. Whoops, I didn't mean to do that. I don't know where it went. Oh well, so the abruption was the other picture. Okay, so the abruption. Now, which one is it, the previa or the abruption pain? What
The
else?
Abruption.
Eruption.
Okay, an acute onset would be the abruption. Yeah, that's painful because it's tearing away. Okay, what else would you associate with an abruption?
Rigid abdomen.
Yeah, yes, rigid abdomen. What else?
Hemorrhage.
Hemorrhage. Yep. Anything else?
The
For some
mortality rate.
Yeah,
Emergency
mortality.
C-section.
Yeah, emergency. Yeah. Vaginal bleeding occurs on both of them, right? What about pain? Does the previa cause pain?
No.
No.
No, not usually. It's more of a painless bleeding. Okay. All right. Sometimes early in pregnancy, when we're doing an ultrasound, let's say at 18, 20 weeks, if we're doing an ultrasound, we might see a pretty low-lying placenta. It's not completely covering the os. It might just kind of be marginal. As that uterus grows, it actually migrates up. So it's no longer a previa. So we have to monitor early to keep our eye. I could say 6 years working in OB, I never saw a single previa. 6 years, and that's a long time. I saw some low-lying placentas, but they were resolved as the woman progressed through her pregnancy. Preeclampsia is another, what we talked about last week, that we need to review again this week for your exam next week. Okay, so what's a very common client complaint if we're suspecting preeclampsia?
Headache that won't go away with Tylenol.
Okay, headache, classic. Headache unrelieved by Tylenol. What else?
Edema.
Edema of what?
Lower extremities.
Okay, that's kind of common in pregnancy towards the end anyway. What is another classic sign?
Blurred vision.
That would be visual changes like seeing spots or stars. Would be visual, blurred vision is more of a toxicity. What else?
Protein in the brain.
All right. So those are the major and the most common. headaches, protein in the urine, and visual changes. As far as edema goes, it's not considered by research to be necessary to have peripheral, facial, or hand edema, but we do see it. Okay, so we can put it in there. So peripheral and pulmonary edema, both. Okay, good. And then hyperactive deep tendon reflexes. There's a lot of them. What labs would you want to draw if you suspected preeclampsia?
A urinalysis,
Okay, urinalysis.
maybe an ultrasound.
What
Or
would the
an
ultrasound
ultrasound.
tell us? What would the ultrasound tell us, Tracy?
Well, we're assessing the fetus. I'm not totally sure. I just remember I read it. Sorry.
Okay,
Platelet count.
okay, a CBC, and it's going to have the platelets. We need a platelet level. What if you suspected? What would the platelet level be?
Low.
Okay, so some thrombocytopenia, right? We'll see that often with preeclampsia.
A non-stress test.
Not necessarily. We're mostly worried about the mother with preeclampsia. Okay,
Would you do
Liver
like
function.
EKG?
what'd you say, Taylor?
Would you do like an EKG?
Nah.
What about a BUN?
So liver and kidney function?
Yeah, liver and kidney function. So let's do liver enzymes or function test. So that would be ALT and AST. And then other than a urinalysis, creatinine level. Okay. Yes, we need to monitor baby during this, but we don't normally do an ultrasound. We're more concerned about mother because we need to make sure mother is not going to go into any kind of seizure activity. Okay. So we need to do an assessment that way. So we know treating preeclampsia is with magnesium sulfate. Okay, so assessment priorities, because these are the 4 systems or the 4 organs that are affected by preeclampsia. Okay, remember the central nervous system with headache, visual changes, deep tendon reflex activity is increased, irritability of the central nervous system. So she's preeclamptic. Eclamptic would mean she's going to have a seizure if we don't do something. Okay, lungs, pulmonary edema, the liver, okay, elevated enzymes, thrombocytopenia, and then the kidneys, urine output, protein in the urine, increased creatinine. So all those things we have to monitor with our client that has preeclampsia. All right, so we're going to give her some magnesium. What signs would you see if your client was becoming toxic?
Respiratory depression.
Good. What would you see as far as the central nervous system if she was toxic? Think about what the brain does.
Muscle weakness.
Okay, good. Yeah. What else?
Low blood pressure.
Yep, the brain certainly regulates blood pressure, so we're going to say hypotension and bradycardia. Okay. What else besides in the central nervous system?
Decreased level of consciousness.
Okay, some lethargy. Yeah, that's true. And then this is where we get the slurred speech. A lot going on in the brain. Okay, the slurred speech. So it's almost like stroke activity. Okay, slowing down the brain. And then what about the liver? Not probably see much about the liver. It would probably be okay. And then the kidney.
Could you do decreased urinary output?
Yeah. What happens is that magnesium is going to paralyze those kidneys. So maybe no urine output if she becomes toxic. Okay. If it's subtherapeutic, means it's not working. So she's going to be the same thing as if we're not doing anything. Okay. So try to remember preeclampsia based on those systems, and then you'll remember everything that you need to be monitoring for your client, evaluating. Is it working? So let's say, who was it mentioned? Edema. Let's say your client had preeclampsia and she delivered her baby. We usually run that magnesium for another 24 hours after delivery, and because we're looking for resolution, making sure that preeclampsia is going away, it's resolving. Okay, so what things would you see if it was resolving? How do we know it's going away?
You have the edema go down and increase urine output.
Yeah. So all the extra
vital
edema
sign.
is going to be resolved. Yeah, it's going to be either diuresed or sweat. She's going to lose it through diaphoresis or out the urine. Okay, get rid of all the extra fluid. Okay, so there are some things on the exam about molar pregnancies and hyperemesis. Okay, so how would you differentiate the two? What things would you see on a molar pregnancy that you might not find
Molar,
with?
this molar pregnancy, that's not a real pregnancy. That's just when you have cysts on the ovaries, right? Or the what is it, the placenta?
No, actually, it's inside the uterus where the
Okay,
baby.
okay,
Yeah, yeah, massive cysts inside the. Yes, it's not a true pregnancy because it doesn't have any of the maternal DNA from the egg. The egg does not have any maternal DNA in it, even though the sperm does. When they unite, it's just the massive growth of the trophoblastic cells. So it's preeclampsia. Do you know what clinical signs you would see with a molar pregnancy?
Dark brown to bright red vaginal bleeding.
Yep. Right. Good. What else?
Pain in the abdomen.
Okay. Abdominal, pelvic pain. very high HCG levels because of the excess trophoblastic cells. Okay, very high HCG levels. And then,
Fast heart rate or high blood pressure?
not, no, I don't think so. That wouldn't be something, but the nausea and vomiting. Okay, nausea and vomiting. So what about hyperemesis? Would you see those things with hyperemesis gravidarum?
Definitely the nausea and vomiting.
Yeah, you're not gonna, usually we're not concerned about pelvic pain or HCG levels, okay? What would you see? Hyperemesis, other than nausea and vomiting. There's two things.
Dehydration?
What happens when someone, you might not know this, but you're learning, right? If someone is throwing up, not eating, not drinking, your stomach is a bunch of acid, right? Throwing up. What
Alkalosis.
happened? I'm sorry?
Light imbalance?
Metabolic alkalosis.
Alkalos. How do I even spell that? That's not right. Alkyl, isn't it? I don't know if that's how you spell it or not. It doesn't look right. Yes, alkalosis. So losing a lot of acid plus what?
Hypokalemia.
Hmm?
Hypokalemia.
Excellent. So this is a metabolic, yes. Alkalosis. Okay. Isn't that funny how you think of a word and you just can't remember how to spell it, Alkaline. Okay. Alkalosis, yes, metabolic alkalosis. So dehydration, hypokalemia. Okay, so what are some early interventions for either one of these clients? Think about client safety. What would you want to do? Now, this is not a position change. Okay. What are you thinking of? What would you want to do for your client? Just try to picture you in a room admitting a client who's got hyperemesis or molar pregnancy and they're miserable. What's the one thing you would want to do?
The
Skip
hyper
fluids.
fluids.
IV fluids, absolutely. And maybe
Medics?
antiemetics and maybe pain medication if they need it, analgesia, okay? Good. So this is how I want you to think through the concepts, okay? I like doing that because it just helps you put things together, okay? And then I showed this one to Thomas earlier. Okay, this is another way of looking at a pathway. How a client, what would you see? What's going on? What are your priorities? What should you monitor? And what are some signs of resolution? Okay. In other words, evaluation. So for preeclampsia, labor induction, we talked about today. Hyperemesis, we talked about. Bleeding in pregnancy. Now, what's bleeding in pregnancy? What am I referring to? Early and late. If you have a client in her first trimester and she's bleeding, what things are you thinking?
Abortion, spontaneous
Okay.
miscarriage.
Spontaneous abortion. Anything else?
Abortion.
Not necessarily early in pregnancy abruption. You might see it with Previa if she has a low-lying placenta and she's 13 weeks pregnant. Yeah, you might. Let's see. And then what about later in pregnancy? What are some bleeding issues? The Previa again, and then the abruption. Okay. You might see it with ectopic pregnancies in the first trimester, might you? With molar pregnancy, you might see it early in pregnancy. Yep. Hyperglycemia in pregnancy. Diabetes. So with hyperglycemia in pregnancy, the beginning of the pregnancy, what would you see?
Is it the glycosuria, the polydipsia, polyuria, and polyphagia?
Yep. So your client with hyperglycemia would see that. That's right. I just posted something for you to look at. For diabetes. Let me pull it up here. And we'll finish up. Number one, that solving the OB calculations is showing right now, okay? So you can download this. So high-risk pregnancy, we're talking about a Hispanic patient, a client with pre-gestational diabetes, in other words, type 2, or she could have type 1. And you can go through this, but what I want you to see is the care plan. Okay, so early in pregnancy with a diabetic, we're talking about signs and symptoms of hypo and hyperglycemia, teaching about target levels, right? And then just supporting her by monitoring, educating her about her glucose levels, and then referral to high risk to co-manage, and then fetal surveillance in that last trimester, BPP, ultrasounds, and non-stress tests. What's the plan for labor? And then postpartum important concepts in breastfeeding. And then early and late. So early in pregnancy, hyperglycemia, we might see some congenital disorders or defects. Cardiac heart defects in the fetus, limb deformities, spontaneous abortions. Later, stillbirth. Okay, it's not listed. Extreme prematurity, macrosomia, birth injuries, and so forth. Okay, so you can study this one too. Okay, this kind of puts it all together for you. Anything else? Whew. So your chapters 17 is the high risk labor and delivery. So, you know, the PowerPoint I'm giving you pretty much covers everything you need to know in that chapter. Okay, but if you need extra help with it, I'll be glad to help with that, and then refer to your text to guide you in that. Okay, so make sure you attend the schedule this week, attend one of the review study sessions that we're having. and look at the schedule and see which one you can attend. Now, if you didn't attend any last exam and you didn't watch any recordings, then you need to do that for this exam, okay? You don't have to attend, it's recommended, but at least watch some of the recordings, okay, if you can't actually attend. All right,
Is the schedule for that in the announcements, or where can I find that?
it's in the announcements, yeah. Yes, it is. Welcome to week 6. Exam 2 study session, it's in both of those. The end exam 2 study session and schedule. Here's where the PowerPoint is for the exam. That's the long one that has everything on it. And then the schedule, who's doing what. And then below that is a list of pre-recorded short videos like we had before.
Does Professor McBride have her Kahoot where we can log in and play against the, I guess, the robots on there?
Actually, she had a schedule I think she did one this morning, and she does have a recording of it. Is that what you're talking about?
Well, with our, like with my Pete's
Mhm.
class, she gives us a link that we can just click on the link and then play the game like against
Okay.
the computer or whatever.
Not that I know of.
Yes.
She had one today, and I'll put the recording up, and then she has one again on the 23rd, which is next Tuesday.
Is it
No,
possible
I don't
to
think,
find out if she can make them available, only because some of us can't meet those scheduled times?
and you want to go? Okay, yeah.
Actually, I hate to butt in, but if you look up McBride MD on Kahoot, you can play the Kahoot with the robots. So it is available on there. You just have to search it by
You
McBride
have to
MD.
search by her name.
Yep,
Okay.
McBride
Okay.
MD, and you can find a Kahoot and play it by yourself.
Okay, you got that? If
Yes, thank you.
if I find a link, I'll share it with you, okay? All right. All right, I think we're done for the day. Right, I'm gonna post that recording next and upload that other PowerPoint for you, okay? All righty. Y'all were quiet today. All right, I see you.
Thank you. Bye.
You're welcome, Cassandra.